Good evening. I'd like to welcome everybody to this evening's Scrutiny Committee of the Health, Housing and Adult Social Care. My name is Councillor Jane Burton. I'm chair of the committee, and I've just got some housekeeping things to go through first. First of all, we've got apologies from Councillor Wilson, who's subbed today by Councillor Clark. I'd also like to welcome Councillor Moroney as a new member to the committee. So welcome, thank you. Next, I wanted to ask any declarations of interest. Councillor Steels-Walshaw.
I will make a declaration for the second paper, the Homelessness Pathways one, as it mentions changing lives. Previously, I was working for Changing Lives. I am no longer and was managing a few of those contracts, but just for the sake of transparency, I'm no longer working for Changing Lives.
Okay, thank you very much for that, Councillor. Now, the next thing, we have minutes to approve. We've got 3 sets of minutes. We've caught up by the looks of things. So first of all, has everybody had a chance to look at the minutes of the 15th of May? And are there any points that you'd like to raise about the minutes of the 15th of May? Councillor Rose.
Yeah, the matters arising. Is it better to take them all at the end of all 3 minutes of approvals? They're not matters of accuracy.
Okay, so I think, yeah. So nobody else has got any issues with 15th of May, 12th of June. Nope. 10th of July. Nope. So go for it, Councillor Rose.
Thanks. It was just in regards to the regarding the briefing on adult autism and ADHD assessment services. I think the thing that has caused me and lots of the people outside of this room involved in that process some grief is one of the things that wasn't mentioned in the. It was confirmed that, but specifically, the main change that had occurred up to that point and was noted at that meeting was this split into having priority and non-priority diagnosis. Priority diagnosis has most of the references here, but the non-priority diagnosis doesn't. There's no waiting time. There's no diagnosis pathway in York. So there should be some reference to that, I think, in the bullets, and it might just be a bullet that says note that non-priority patients don't have a path through to a diagnosis in York currently, or something like that. But it'd be good to get the ICB's steer on what that sentence should be, I think, because I don't think I would represent it accurately. But if that could be referenced, that'd be good. I know that we then got in the work plan, we've got the big review coming through next time round. So there's a big conversation coming about it anyway. But just wanted to call that out really as a
that's fine.
As a point of
good. Thank you. We want to be so. Apart from that, everybody's happy with the minutes of the last 3 meetings. Good. So they're passed for approval. Thank you. Okay. Next we have public participation, and today we have a late applicant who I thought was worth having here to listen to, and that's Richard Harrison of Citywide Health, who's going to talk on the first item on the agenda. Well, item 4 on the agenda, but the first topic. So could you come to the table, please? Yes. Now, I don't know if you've done this before, but you have 3 minutes to speak. If you want, I can give you a reminder at 30 seconds to go in your 3 minutes. Otherwise, I can let you just talk for 3 minutes. Yes. Yeah, you'll have to turn your microphone on as well.
Right. Okay.
Okay.
Okay. So I'm Richard Harrison. I'm a pharmacist. I've lived in York for 25 years. In 2010, I opened Haxby Pharmacy, and then in 2012, Huntingdon Pharmacy. And over the next 5 years, I acquired another 5. I think next 3 years, acquired another 5 pharmacies when people retired in Fulford, Poppleton, Tower Court, Waterend, and Bishop Hope Road. In 2019, we rebranded to Citywide Health. That wasn't a takeover. We're still very York based, but that's just what we did as a try and bring it all together. We employ about 50 staff. We dispense around 800,000 prescriptions each year, which is 20% of the city's prescription items, and it's more than anybody else in the city. We provided training and vaccine stewardship to Nimbus Care at Askham Bar during the pandemic, and we were the first pharmacy to deliver COVID vaccines in North Yorkshire. And we worked with York Public Health team during the pandemic to identify the lowest uptake wards, which were Hull Road, Fishergate, Guildhall and Micklegate. And as a result, Citywide Health opened sites at Burnham Sports Centre and St Lawrence Church Hall to increase uptakes in those wards. We've also got sites at New Eastwick and Wigginton. So we've now got 11 COVID sites, and Councillor Rose was volunteered at a number of those sites, so thank you for that. We're the largest provider of COVID and flu vaccines in York, and we carry out housebound vaccinations for a private medical group. The ICB commissioned us to carry out COVID vaccinations in North Yorkshire, but apart from that, all our activities in York. Myself and all my staff live in York, and that's our continued focus, community pharmacy in York. I sent on a document earlier today which shared a video from Community Pharmacy England which explained the situation that community pharmacies are in. Members of the previous government stated that they wanted to close 3,000 pharmacies and have done this by freezing pharmacy funding at 2015 levels. Costs have increased by 40% during the last 9 years, meaning that pharmacies are no longer sustainable. The action was aimed at reducing clusters and encouraging mergers, but the consequence of this has been closures have been purely based upon balance sheets, and that's happened in some of the most deprived areas, with community pharmacies losing their community pharmacies, creating pharmacy deserts, and that's exactly what's happened in Clifton. Citywide Health hasn't closed any pharmacies, but we did merge 2 in Huntington. We've managed to survive on the additional funding from COVID, as well as taking advantage of the new services, Pharmacy First, hypertension and contraception services. This year, we provided 4,000 consultations for these services, meaning that 4,000 people have been able to access same-day appointments and gain treatment. Women have been able to gain antibiotics for urinary tract infections. Children have been able to have antibiotics for ear infections. And what that's done is, as well as those 4,000 people getting same-day treatments, it's created 150 days of additional GP time to offer routine appointments. If you look in the email I sent around, you can see that there's 2 particular practices in York that really have embraced this, and that's York Medical Group and Haxby Group. And Haxby have included Pharmacy First in their GP-led triage, which has now helped to reduce their routine list down from 12 weeks down to just 2 weeks now. So that's made a real big difference. Okay, so Clifton. So before Citywide Health, I worked in all 3 pharmacies in Clifton. The health inequalities in the ward are stark, and it's been sad to see them all close. When the news was announced that Boots would close, I submitted an application to the ICB and contacted Councillor Myers to help with the petition. We secured the building 8 at Clifton ready to take over, and we applied to the ICB. We had the backing of 600 residents, local GPs, Health and Wellbeing Board, Councillors Myers Wells and Rachel Maskell. We hope the application and our past performance of delivering high level of pharmacy services would help persuade the ICB that Citywide Health opening a pharmacy in Clifton would reduce health inequalities, but that's not the case. The application was refused. The reasons were there will be no improvement or better access in granting the application. With all the work we've done at Pharmacy First, I think it's obvious that would be happen. And then also the other reason is there is a reasonable choice in relation to obtaining pharmacy services in 1.5 miles. So what that's saying is that it's acceptable for a frail pensioner or somebody with a disability to have a 3-mile round trip to a nearer pharmacy. Okay.
Sorry, thank you
Okay.
very much for that. Obviously, it's a very limited amount
Yeah.
of time to tell us all what
Right.
you're doing. And has anybody got any questions they'd like to put to the speaker at this point? Councillor Myers.
Richard, thanks for coming to speak to us. What is the appeal process, and are you going to participate in sending an appeal to the ICB?
So this is difficult. So that what's happened is that we've been paying rent and rates on that building, and we've been doing that now. We're now 6 months in. The appeal process will be another 6 months, and it's the appeal is not something that I can handle myself. It's going to require a solicitor, so it's going to involve a significant investment of time and money. And my concern is that we do all that, we're 6 months down the line and that gets refused. And then Clifton still doesn't have a pharmacy, and we've invested a lot of money in trying to get the pharmacy back open. So I'm not sure what we're doing at the moment. I guess, you know, when Hayley's speaking soon, so she might be able to cast some more light on that.
Okay, councillor Bassey.
Thank you, Chair. Yeah, I'd like to get some information from you about blister packs.
Okay.
And I'm asking because my father, who's now in a care home, went through a process at the beginning of this year where he became increasingly unwell. People were coming in a couple of times a day to help with medication, as well as family carers. And the reason for my question is that it quickly became clear that when you have several people coming into a house to help someone with their medication, it requires a degree of coordination about putting medicines together by day and so on and so forth, so that everyone knows who is whether the individual has had their medication and that there aren't duplications and all of that.
Yeah.
And what quickly became clear was that it was quite a complicated process, and it relied on, it seemed like, goodwill between the NHS and pharmacies, and that it was quite a difficult thing to organise. There could be considerable delays and so on and so forth. So I just wondered if you'd give us a sense of how that works. And it may be that not everyone knows about blister packs, because I didn't know about it until I had to. So maybe give us a sense of how it works and what could work better, etc.
Yeah, so there's a number of, so the situation in 2015 is totally different to what it is now. So in 2015 there was margin in pharmacy to be able to offer services that we didn't charge for. So we used to previously offer a free delivery service, and it wasn't free, it was costing us a lot of money to run a van and pay the drivers. And similarly to unpack medicines out of the packs that they come in, put them into blisters, seal them back up, there was a cost to that as well. And the goodwill was that the pharmacy owners were bearing that cost, so to help the patients. As the funding's been frozen and costs have increased, we've had to start cutting back on things. And so free deliveries is something that Citywide Health used to do and doesn't do now. Now you have to buy an annual membership for deliveries. And free trays was something that we used to do, free packed trays, and now we can't do that. So now we charge for that. In a situation where somebody isn't able to afford that, then the other options in the case that you've given there was that we actually provide them with a refillable plastic tray. So it clips open, a member of the family puts the tablets into the thing and clips it back shut, and then you pull the drawers open and close again. And that means it can be reused. So there's better for the environment and the fact that you haven't got a lot of plastic getting used, and you can do that yourself. Or we can provide mark sheets where, you know, a member of the family comes in, gives them out the original packs, and then marks on the sheet that they've actually been given. So when the next person comes in, they can see what's actually been happening. But the reduction in services is directly linked to the previous government's attempts to close community pharmacies by strangling by freezing the funding.
Thank you. Yes, and so to maybe bring clarity to my experience of it, was that if you've got different people coming in the morning to the afternoon, what is essentially designed to enable carers to have an easier time of looking after a loved one who's requiring a lot of care becomes ever more complicated if there isn't a system that enables everyone who's coming in to be clear that they're giving the right medication and so on and so forth. And I think what you're saying to us is that the cuts that have taken place are making it financially very difficult for pharmacies to offer that service.
Even to open the door. You know, if you look at the pharmacies in York that have closed, they're closed because they're not making any money. The only reason why we're still here is because we've really, you know, we do things. So when COVID came along, we embraced COVID and we're doing the COVID vaccinations, and we've done 4,000 of those pharmacy first and hypertension consultations. If we hadn't done that, we would be in that situation. You know, when you've got a multinational, what they do is they look at the balance sheet, and if it's, they look at Boots, looked at Clifton, just struck it off. Lloyd's looked at Clifton, struck it off. Unfortunately, in the run up to 2015, when we were buying pharmacies, the bank took a personal guarantee over me and my house. So I can't just write things off, because if I do, I literally will lose everything as such. So I've got to keep fighting on and hope that the new government will respect community pharmacy, and there will be some investment back into the sector.
Thank you. Yeah.
Thank you. And one last question from Councillor Myers.
And I think over there as well.
Oh, sorry.
Yeah.
Yeah, no, that's fine.
Okay, thank you, Richard. Just to go back to Clifton.
Yep.
And I know you share concerns about the people of Clifton's health inequalities. I
Yep.
just wondered if you could elaborate on that from your perspective, providing pharmacy services, and also a little bit more about the impact on GP services that you can reduce.
Yeah. So if you look at the closest pharmacies to the one that's closing Clifton, actually two of them are ours. So there's the one at Tower Court, and before the closure that was doing 8,000 prescription items a month, and it's now doing 14,000. So you know, that's a 70% increase virtually overnight. You know, Tesco is struggling to turn prescriptions around in a reasonable amount of time. And all the pharmacies around there are struggling. And then, so when I put in the application to the ICB, you know, Vicky Middleton from Pride Medical Group was very supportive of the application. And you know, what's happening with the GPs in that particular area is that the patients can't easily access a pharmacy. So when they've got one of those conditions, if they've got an infected insect bite, rather than actually going to the pharmacy, walking in, having a consultation, and getting the antibiotics and going home, they're either going to the doctors or they're going to A&E. So it's having a, you know, those people in Clifton can't access the healthcare that people in Haxby and Wigginton can, for example, where they've got, you know, our pharmacy there, which they can walk into and get those particular services.
So Councillor Hook.
Thank you, Chair. Just really, you mentioned Tower Court, and I
Yep.
know one of the concerns about Tower Court is the car parking, where
Yep.
people can get really charged for
Yep.
going twice if they
Yep.
just forget, which people often do, to
Yep.
sign in. Is that causing a real problem?
So we having within the pharmacy, we've got a iPad on the counter, and if anybody comes into the pharmacy and puts their number plate into that iPad, they can park as long as they want for 24 hours. The problems happen when people don't see that, and then it's not always the pharmacy. They might come to the pharmacy in the morning, and then they might go away, then they might come back and go to the farm foods or the dentist and then get the parking fine. Unfortunately, with that situation there, it's one of those ones where what happened was the Regis units above, there was a chap, we buy any car type chap, hired one of those units and then parked 60 cars out in the car park to sell his cars. So to get around that, the landlord then put the ANPR system in there, and unfortunately the companies that operate those systems are you know, they're fairly ruthless. So you know, if you say, oh, I had an appointment in the doctor in the morning and then I had to go home because my mum needed, you know, I was looking after my mum, and then I came back in the afternoon to go to farm foods to get the shopping, they just don't care. So it is causing a problem. I guess when it first started, it was causing more of a problem, but because more people know about it now, then you know, we're managing to work with it. I'd rather it wasn't there, and I've helped a number of people get their fines reduced, and sometimes reduced to zero. But it's not an ideal situation.
Thank you.
Thank you. Councillor Moroney.
Thank you, Chair. A point of clarification, if I may. Could
Yeah.
you repeat the name of your organisation, please?
So the name of the company is Haxby Group Pharmacy Limited, and we trade as Citywide Health.
Thank you. That's answered my question.
Okay. Any more questions? One last one from a brief one.
A brief one, yes. I just thought it, as we have you here, to get your thoughts on going forwards on the value of prescription dispensing machines potentially going forwards. I know there's one in Haxby that operates. Whether you think they have a part to play in ensuring that people can get their prescriptions.
So there's three of those in York, and they're all ours.
Yeah.
So we've got one at Haxby, one in Huntington, and one at Tower Court. And the plan was to put one in Clifton as well, but obviously that's on ice at the moment. Obviously what they do is they allow people to collect their medicines, but it's not a pharmacist. But what it does do is that it means that if a pharmacy is quite intensive and people are just wanting to quickly come in to collect their medicines, that they're not stuck behind somebody who's got a long and complicated queue. So it does give a better level of service to the people who want to just come and collect their medicines. And the people that are in the pharmacy get more attention from the pharmacist. So that it's definitely something that works. And I'd like to have more of them. The building has to be right. And Clifton is double fronted, so that would be perfect. We could have the machine in one half, 2 consultation rooms. It's actually fit out. The boots, we've still got it fit out as boots. I could open tomorrow virtually if we had the contract. But no, that is something that that is in the plans, but it just depends, I guess, what happens with Clifton.
And do you think that potentially that model could serve in remoter areas and in rural areas where people can, I mean, you talked about having a 1.5 mile walk to surgery. There are people going a lot further than that. I'm just wondering whether you think.
So the problem is that as well as freezing the finance, the NHS has changed the funding away from providing prescription services more to providing pharmacy first and consultation services. So there used to be about £1 an item gross margin in the dispensing items, and that's been reduced, and then they've put money into the pharmacy first funding. The concern is that, that just before the election, they announced that there was going to be £645 million put into pharmacy, and that was the big soundbite, that we do care about community pharmacy. We put 645 million in there, but that was based upon pharmacies doing up to 3,000 pharmacy first consultations each month. And so my busiest site at Haxby is doing 70, 80 a month. So actually the projection is that 645 million that was earmarked for community pharmacy, by the time we get to the end of March, is only going to be 180 million spent. So it was promised 645, and the Treasury is going to be pulling back nearly 450 million of that. So it's 645 million hasn't been invested in community pharmacy. So the rural area question is, the problem is that the dispensing, the machine, and doesn't actually pay for itself. It's the people coming into the pharmacy, seeing the pharmacist, having the consultations that funds the operations of the pharmacy these days.
Thank you.
Thank you. Right, I want to thank you, Mr. Harrison, very much for coming along. You're welcome to sit there and listen to the meeting if you want to. But if you wouldn't mind going back to the
I'll stay for the rest of the pharmacy bit. Okay, thank you.
Thank you very much. Okay, so thank you very much for that. It was very excellent questions there. So we're coming to the next part of the meeting, which is on community pharmacy provision in York. And for this part of the meeting, we have Peter Roderick, who is Director of Public Health, Jennifer Irvin, who is Public Health Specialist Practitioner, and Hayley Patterson, who is Programme Lead, Primary Care, NHS Humber and North Yorkshire ICB. So you probably all know the score. You've got to press your speaker when you're speaking. the microphone when you're speaking. And if you'd like to talk about this.
Thank you, Chair. And
Thanks.
yeah, I'll kick us off if that's okay.
Okay.
My colleagues again to follow. And yeah, good evening, everyone. And I'll do a little bit of background to this report. I think we've really benefited from good 25 minutes of hearing actually from Rich and some of the questions as well. So there's some aspects of the conversation which have already started, which is really helpful indeed. But I wanted to set a bit of a background, particularly about the report you've got in front of you and what the details are, because what the report really seeks to do is to start with some of the broader context, which actually we've heard a little bit about, before moving on to some of the specific issues. And a point, I guess, to note, first of all, is about this committee and relationship to community pharmacy services, and, you know, escapes of anyone's sort of attention that the City of York Council as a body is not responsible for pharmacy services. Obviously, this committee has a remit around health services in the NHS in general in terms of its oversight and scrutiny, particularly of service changes within scrutiny legislation. But also, and this is the bit that might need that little bit of clarification, and my colleague Jen will discuss it more in detail, the public health team within the authority do have a small role within the provision of community pharmacy, in that we have duties around, statutory duties around producing a pharmaceutical needs assessment, and duties around commenting on applications around pharmacies that are proposed to be opened in a local area in relation to that needs assessment. So whilst not being experts in pharmaceutical services ourselves, we are good at assessing the needs of the population and how provision of services might match the need, hence our role within that. So just wanted to sort of clarify that at the start, and that's why some of the report goes into the detail it does. Richard does a fantastic job of illustrating some of the challenges, but I wanted to set out at the start of the report the fact that from a public health perspective, at least, the community pharmacy, it should be seen as a massive asset for our city, and in fact, in some ways, a public health intervention into the health of the population. We know that the NHS is currently sitting on sort of 7.4 million outpatient and diagnostic procedures that need to happen within the NHS waiting list issue. We know that some waiting lists for general practice services are very high, and the length of time you'll wait for a routine appointment particularly has never been more pressurised, and we know that our accident and emergency departments are often full to bursting. Some people are often sitting there for upwards of 12 hours. Whilst community pharmacy can never solve all of that, it has actually a huge range and a wide reach into communities in terms of that same day service, that routine care, that management of routine health conditions, of which, you know, we probably see around 1 in 4 of our population with a long-term condition in the city. So 25% of the population having conditions where you might need medication to be dispensed, you might need that advice and guidance and over-the-counter medication too. So there's a huge benefit to having our spread of community pharmacies in the city, but there are huge challenges as well. And Richard has mentioned the 2 ones the paper highlights, really. Funding, and if you just look at real terms, it decreased through a variety of mechanisms, but part of that is through sort of the margins that pharmacies will get through dispensing. The Health and Social Care Select Committee estimated it was around about a 30% reduction in funding since 2015. And then workforce, it's brilliant to see pharmacists actually finding themselves into lots of different parts of the health and social care system. They don't just work within community pharmacy. You'll find pharmacists in hospitals, you'll find them within primary care networks now and in other places. But from a training place perspective, that hasn't necessarily caught up. So actually in that expansion and moving pharmacists to different bit of the systems, it does mean actually understand that community pharmacists to recruit is becoming increasingly a challenge. So there's significant challenges. As a council, we obviously have our role within the P&A, and I think that broader role to try and support the health assets like pharmacists that we have in our community through a variety of mechanisms. Jen is going to explain a little bit about, therefore, the pharmaceutical needs assessment and how that fits into it and what we do as a public health team. So I'll hand over to you, Jen.
Thank you very much. Yeah, so as Peter sort of outlined for you, as a local authority, we don't have any sort of commissioning roles around pharmacies per se. We do have this responsibility that comes from the Health and Wellbeing Board, that in most parts of the country they delegate into the public health team to do around this PNA, this pharmaceutical needs assessment. And so this is something that happens on a rolling basis every 3 years, and every part of the country sort of lines up with their schedule on that. And really the purpose of it is to understand whether there are enough pharmacies in the right places doing roughly the right sorts of things for the needs of the local population. And so that's exactly what we did. So our current pharmacy that we have at the minute covers 2022 to 2024. We're sort of in the starting place of thinking about 2025's pharmacy just now. And we came to 29 conclusions, which sounds like an awful lot, but really what we were saying was, we felt at the time that we published the P&A, there was adequate choice of pharmacies with good geographic spread. And that is a good place to be in. We spoke a little bit about the differences between weekdays and weekends and those sorts of things, but that was the sort of overarching conclusion that we came to. It's probably worth saying just at this point that there is no, in the legislation or the guidance, etc., there is no sort of national benchmark on what good looks like. So if we think about schools, there's discussions around catchment area and capacity in the school. If we think about GPs, there's a sort of 10,000 of the population, this is what you'd expect for GP coverage. That doesn't exist in the same way for pharmacies. It is up to local determination. And the way that we looked at it was a 15-minute walk felt about right. We recognise that York is a pretty dense city, and people that live in our city have come to understand and expect that there is reasonable coverage of pharmacy. So that's the benchmark that we'd gone on, and we used our mapping tools to sort of articulate that out. And that's what those conclusions were based on, really. So obviously things change over time. So subsequently to publishing, we get notified if something changes, and things change quite a bit. We have changes in who owns pharmacies, we get changes in opening hours, sometimes we get changes to supplementary opening hours, and sometimes pharmacies close. And so when those things happen, we get notified. There's quite a few processes it goes through, but we hear from the ICB that has happened, and we will look at it and say, is that a substantial change? And so sometimes those things aren't a substantial change. We've had a series, you'll see detailed in the report, that we've had a series of closures where actually the nearest next pharmacy was really not that far away at all, and we thought that the coverage was still sort of adequate, and the conclusions that we made in the original P&A stood. They were still valid. That isn't always the case, and so I've detailed out 2 changes or 2 closures this year in 2024, and one of those is the Boots closure, which has been discussed by our speaker today. And so you'll see with that one that we came to the conclusion that actually now a part of the city that was within that 15-minute walking threshold now isn't. So on the map on page, where are we? Page 25. The sort of 15-minute walk is covered in that tan yellow colour, and anything that's not is sort of outside of that. And the little red dot is where the pharmacy used to be. And so the other part of the responsibility that we have is when new applications come in, as Peter was saying. And so very briefly, I won't go into all of the details here. Essentially, the pharmacy closed in Clifton in February. There were 3 applications put in by 3 different organisations, and we responded to each of those on their own merits, as through the conduit of the Health and Wellbeing Board. And actually, to all 3 of them, we said that we would support the application, because we could see that there was this need, there was this gap, referring back to that map I was just spoken about. And then that gets submitted through to the ICB. Lots of organisations and bodies are entitled to respond. So other pharmacies in the area, GP practices, those kinds of organisations that might have a vested interest are invited to respond. And so that's what we did. And then we waited to see, and as you've heard discussed, the ICB made the decision to not to accept, to reject all of those applications at that time. So that's where we are at the minute. I think I'm handing back to you now.
Yeah, very briefly, I'll introduce Hayley in a second. One last thing to clarify is that the pharmaceutical risk assessment, as part of it, has quite widespread public consultation as well. So a lot of the findings around, I guess, the two pillars here are access. You know, where are they, and then quality. Are they offering both the range of services, the quality of services, and other factors within it? And we asked the public a lot of questions and get good responses on that, which is where some of that the conclusions come from around the fact that at the time we wrote the needs assessment, generally we felt on both cases, most areas of York were covered adequately. Now, of course, there will always be areas where it's further to go. And as Jen was saying, the lack of any national distance benchmark means that we have to take an approach which balances the fact that you can't have a pharmacy on every street corner with the need that we think we have. I'll introduce Hayley, and first of all, really just to thank Hayley actually for coming and addressing the committee from the ICB. We work closely with Hayley as ICB colleagues. We are all part of the integrated care system with the local authority, with the ICB, and really want to make sure that we maximise that asset that is community pharmacy locally with pharmacy, whilst thinking about the challenges as well. So I think Hayley's going to talk a little bit about the ICB's role in this, and then I think after that, Chair, we're okay to go to questions. So Hayley.
Okay, thank you.
Thank you. I was just going to give a bit of a background in relation to how the pharmacy committee within Humber North Yorkshire ICB consider applications. I think just responding to some of the comments that we've had from councillors in relation to the rejection of the non-supporting of the applications that we had. So for each pharmacy application that comes into us, we need to write reports, and we've got a pharmacy committee that we have South Yorkshire and West Yorkshire on there as well. So we have a committees in common that we consider all these applications, but within each application there are regulations that need to be considered, and each regulation is different depending on the application that we're considering, and within the application form it sets out those regulations, and then the contractor needs to respond to those and provide as much information as possible so the committee can be assured that the regulations are met or not met. In that case, we've got a lay member on there who is part of our decision-making panel, and we have our assistant head of primary care who is a decision maker for Humber North Yorkshire, and we've also got a clinical advisor who kind of talks through the applications once they've been presented and presents his view, and then the decision goes to the decision makers to make. So in terms of the benefits, in terms of the applications that have been submitted for Clifton, we did have 3, and the main regulation for them is Regulation 18, and that I won't go into the details of that because it's quite detailed and not very interesting. But it does look at areas such as Richard's talked about, sort of improving better access, and whether these are included in the current P&A. And I know Jenny's talked about the P&A, and we're just starting to look at writing the other one. But for a lot of the applications for new pharmacies, it is pinned on what is in the current P&A, and within there at the moment it does say there aren't any gaps in pharmacy services. I know we've looked at a supplementary statement and that has been issued, but it's just been very clear about what the supplementary statement is and it isn't. So it's a statement of fact, and so they don't make any assessment of the impact of the change that the closure in this case would have had on pharmacy services. So effectively they update what the P&A says about the availability of pharmacy services, but they're not a vehicle for updating what it actually says about the need for pharmacy services. So because there were no gaps identified within the P&A, the committee weren't assured that regulation was met. It does talk about, and I know we've talked about pharmacies within 15 minutes and pharmacies close by. Richard, you've talked about that already. And so the committee felt that there was reasonable choice of pharmacy in the area. So for all 3 of applications, there were between 10 and 12 pharmacies within 1.5 miles, with either the secured premises, which Richard talked about that he'd got for his application, or the proposed premises, which some of the other applications had. Some of the regulations for Regulation 18 talk about people with protected characteristics and the access to specific services that are currently difficult for them to access. So within the applications, the committee weren't assured that that part of the regulation was met. And then it does talk about innovative approaches in relation to the delivery of pharmacy services, which would benefit people. And again, the committee were just not assured that regulation was met, so didn't feel assured. So all the elements together need to be met for that, in order to support the application. So I think sometimes and some of the applications have talked about, and some of the information in the report is that just because we've got a pharmacy close doesn't necessarily mean it's a gap, and that's why we'll look at the choice of other pharmacies close by. And within all of the applications that came in, there was that choice within 1.5 miles. As one of the councillors has talked about, there is an appeal process. So if the contractors, are able to go that, and they do get the right of appeal if an application is not supported, whether it's a unforeseen benefit like yours was, Richard, or any other application that isn't supported, they do have the right of appeal. At the moment, I know you mentioned 6 months, Richard, but I think at the moment, so we've just had one that took about 3 months. So it's not necessarily, I'm not promising that because it's not necessarily set in stone, but it wasn't taken as long as that. So all the contractors that didn't have their applications supported do have that right of appeal process. And if they do come in, then we'll work through that with the NHS Appeals Authority. And if they overturn our decision, then we'll work with the contractors on what we need to do next. Thank you.
Okay, thank you. You finished presenting, and that's great. So we're going to go over now to questions from the members of the committee, and the first person who'd like to speak is Councillor Runciman, and then Councillor Rose. Okay, thank you.
Thank you, Chair. Having dealt with these over many years, this is the first one where I have an awful lot of questions, but I will try and find them down. The first thing is, I'm really surprised that there were 3 pharmacists who thought that it was worth opening a pharmacy in Clifton, and that application was refused. I'm really surprised that something wasn't done about that. I can remember very vividly how busy that pharmacy was in the COVID epidemic, and we had awful trouble with people getting in and getting what they needed to. And I would hope that the ICB will look at that one again, because I think that's really important. Next thing I want to say is the map on page 25 in paragraph 18. It's the bits around the edges that bother me. And it's not a matter of whether you can walk 15 miles. It's a matter of whether there's a bus. And I'm quite sure that Councillor Vassy will say something about it, but I have been banging on about having a pharmacy in Weldrake, and a surgery for that matter, for a very long time. And Weldrake, you can't walk 15 minutes to a pharmacy. You can't get to Elvington by bus. And I've been checking the bits around the edges. I'm pleased that Dunnington's got a pharmacy, Elvington's got a pharmacy. I'm not sure about Stockton on the Forest, because their surgery closed down as well. And I don't think this report actually covers all the areas that it should. I admit to say I forgot to look at rural West, but I'm sure Councillor Hook will talk about that. And then the third and last thing I want to say is about access. You talk about access in terms of walking distance. That's okay if somebody can walk. In my ward, we have a pharmacy with an enormous step. And when I go there, I nearly always have to help somebody in, and it isn't accessible to people in wheelchairs or people who've got severe mobility problems because of that step. And it's easily that height. I don't exaggerate at all. And I have complained about it numerous times because my residents complain to me about it. So I think there's 2 aspects of access. Can you get there? Can the person get there? Can they walk for 15 minutes or whatever? And when they get there, can they get in? And I'm not sure that's being looked at properly at all. So I'm sorry to be very critical, but it's a really important thing for very elderly people that are desperate to get their medication. Thank you.
No problem, thank you. Councillor Rose.
Yeah, I mean, not to piggyback off the criticality, but I've got a bunch of questions that are more broad and more positive in some respects. But just to pick up the Clifton and the ICB bit specifically, and it isn't a criticism, but I am slightly baffled by it as well. And looking at the map in front of us, we've also got Skelton there as a village that on this map, maybe it's just not marked because of the way it's cropped, whatever, but Skelton, an entire village of 1,000+ people that has no pharmacy needs. And I mean, I cycled to Skelton from Rawcliffe and was not happy cycling, so I wouldn't want to walk it. And it feels like a big obvious gap. Ditto for that bit of Clifton. I go past that daily at the moment, and there's a lot of people there who don't have their own car. There's a lot of people there who will struggle to travel to the other sides, either into the city centre, which is not exactly the least congested bit of the city to try and travel to, or out to Clifton Moor, where there are parking challenges and bus routes don't link up because those bus routes got the stripe of gap up to Rawcliffe as well. So I guess I'm just trying to get my head around how the ICB could end up with the decision it's got there, whether it just looks at the document, which perhaps needs a bit of a review in the P&A, to say that actually there are a few gaps, maybe. Whether it's just taking, well, the P&A says there's no gaps, so we're not even going to think more than that. Or if there's some other reason why a relatively gaping gap in that specific community, which is also an area of high need in the city, and then places like Skelton and stuff, are we in a situation where we're just not going to have any new pharmacies at all in York if one closes down? And just as the counterpoint of view, I live bang between the 6 dots in the middle of Aiken, where I needed a pharmacy a few months ago and looked online, it said 0.2 miles, 0.3 miles, 0.6 miles away. Very lucky to be there. And if one of those closes down and the ICB says you can't reopen a new one, I would understand that decision. So it's not a point in general universality, but this specific point we're talking about here, I just can't get my head around how this is in a situation where maybe one application isn't the right application, but we're rejecting kind of carte blanche. If you're able to shed some light on that, it'd be really appreciated.
I think the committee can only make a decision on the information that they've got. So it all depends on what is in the report that is submitted by the contractor. And so if all of that information isn't in there, it's you just got to go with what's in front of you. And if the committee just were not assured that information was there in terms of what additionality or what other improvements to access that could be offered by the contractors that submitted their applications.
Sorry, Peter.
Thank you. And if I may follow that, Chair, I think it's I think the comments are really helpful and really valid about accessibility once someone is in a pharmacy and the different modes of transport to pharmacy. I guess my counterpoint to this is we did our pharmaceutical needs assessment in conjunction with North Yorkshire. We used the same team, we followed the same process. North Yorkshire as an area would kill for the pharmacy cover that we have in York in terms of the number of people we can find who are within walking distance as a proportion of the population is, I would say, probably one of the highest in the country. And what the mechanism for raising individual accessibility issues with pharmacies would have been through a public consultation, just, I'm afraid, purely from resources perspective. It's very difficult for us to go and assess all pharmacies for their accessibility issues. So we are through the consultation looking for the public to inform us of where we might need to try and influence contractors in terms of, for a start, complying with equalities legislation and that sort of thing to ensure accessibility. So there are things that the pharmaceutical needs assessment can do, but I wouldn't want to create an expectation that there are some things that it can't do as a tool. It in that sense relies on what the public tell us, and it relies on using, I guess, a general sense of benchmark need against the rest of the country, in which in a dense urban area, we actually do find comparatively, and that's what the conclusions of the report are, that we have generally good access. Now, generally doesn't mean universally, and there will be probably thousands still in the city of York who by any mode of transport find themselves not close, and for some access to a car will be that issue, and for some it would be, even if with a car, it's a long way to go, especially in some of our outlying villages. It's a long way to go from Weldrick, even if you are a driver, to the nearest farm. I do recognise that, but we have that need, I guess, to assess against the general sense of benchmark across the country, and that's why the pharmaceutical needs assessment is what it is. I would then say, when the need arises, subject to a closure, we do issue the supplementary statement. And that's perhaps where the public health team sort of did take that view in Clifton. If you look at that map that you've got around the Clifton area, actually, it's not simply that had opened up, but that's a large, dense urban population, just pure per head of population. We felt that we were talking about multiple, probably into the tens of thousands of people now in an area where access was low. And in that sense, we did issue a statement saying we feel as if there is now a need in the Clifton area. So just wanted to explain that for committee. Thanks, Chair.
I'm just going to, is it a supplementary? Okay.
Just, I guess just
Okay.
a very quick follow-up from that is, I guess I have a concern that if we have our specialist public health team say this is a need, the ICB saying, well, we didn't quite get enough from the applicants to say that it's a need, or taking the situation as a whole that actually we are, you know, absolutely agree with you that we're a very high pharmacy per head area compared to particularly wider North Yorkshire. Are we in a situation here where we're going to really struggle to have new community pharmacies opening, backing all the points made previously around how important community pharmacies are? Or is this an isolated case where maybe the applications could have been done in a slightly different way, where it would have been slightly different? Or is there more weight that we can add as a council to the value and judgments of our local experts over independent ICB panels? How do we get that balance right on this one?
Well, I'll ask Kaylee to come in on that. To be honest, I think probably the most that the public health team could do is say there's a demonstration of what we feel is need. I guess the ICB's consideration of that, Hayley can cover.
So I think it is the application, and I think, as we said before, that it's what is and what is not a supplementary statement, and it isn't an update to the PNA. And I think if a gap has opened up and it is felt to be significant, you would then look at doing a new PNA, but it's not a quick fix. You know, it takes us, you know, nearly a year to write a new PNA. So even if Jeff and Peter suddenly thought, well, actually, this is a really significant gap, and we do need, you know, that then kickstarted a new PNA. We're doing that now for the PNA that is due for 25-28, and so it's not a quick document to kind of update. So even if, you know, instead of the supplementary statement that then kickstarted the start of a new PNA, it wouldn't be ready now. It would, you know, there's kind of a lot of consultation and a lot of work to do on that. So although it's easy for us to say, well, you think there's a gap, so let's have a new PNA. It's not a quick fix. It's not something that happens very quickly.
Okay, so back to Peter.
If I may be slightly tongue in cheek, because we may be here identifying national processes that don't work particularly well, rather than local processes, which I wouldn't therefore sort of I guess defend my ICB colleagues. The regulations, and I've had a go at reading them, are very complex and long, and I think leave a bit to be desired in terms of clarity on what is being asked. I think this issue of the distance one has to travel is very unclear within them, and as Hayley has said, the logistics of having to demonstrate a new need through a process which generally takes, well, it has, I think, 2 bits of public consultation, doesn't it, Jen? Because we have to ask the public the opinion and then put the final document draft out to consultation. Is that right?
That's what we do. Technically, by sort of law, there's only one. There's a 60-day consultation period on the full draft, essentially. But we consider it good practice and have historically been at and asked folk what they think ahead of writing the document, and then people are entitled to comment on the full thing. So technically one, but we do too.
But the logistics sort of are quite a lot. Sorry,
clear, is this when you're writing the PNA?
Yes.
Okay, and from what I got, it's the PNA that wasn't updated when these applications came in, because that would have shown you.
I don't think it wasn't updated. I think, you know, we do issue a supplementary statement. The public health department issue a supplementary statement when there are changes. I think that isn't the vehicle to say there's a gap. You know, the PNA is the vehicle to say that, and I guess the new PNA would say that, but it's not going to say that until, you know, this time next year.
And it takes a year to update the PNA.
Yeah.
I'm sorry if I'm treading on people's toes. I just wanted to say for people who are watching at home, the PNA is a pharmacy needs assessment. Yes.
And it's available on the council's website, just for those.
And available on the council website. Yes. Okay, now I've got a long list of people waiting to speak. So I think if we could try and keep questions shortish, it would be good, because we are overrunning on this, but I think it's very important that we cover this. And when I say shortish, I'm not limiting you. Okay, next is Councillor Smaley.
Thank you, Chair. I've got about 5 points, but in the spirit of what you've just said, I'll keep it very, very short. Firstly, I guess to preface with thanks, because I think it's good for us as a committee to to hear about this, and thank you to the public speaker. I think it is quite annoying to see the map on page 5 exclude a large proportion of the local authority. Like, I know the administration doesn't care about the villages, but it'd be quite nice if sort of formal reports.
So I think that's, I think the administration does care about villages actually.
Anyway, you know, Councillor Vassey's ward isn't included at all in that map, and the vast majority of Councillor Hook's ward isn't included in that map. Another point, I guess I've been a councillor 5 years. I'd say at least a fifth of my casework has been about pharmacies, be it Tower Court and the disaster that is the parking system there, or obviously the Boots closure, which, and you know, thanks to Councillor Myers and Councillor Wells for all the work they did on that as well. So I think, yeah, it's a massive important issue for residents. It's an important issue for the council. On the North Yorkshire point you made, Peter, I really don't think it's equatable. We have far worse health outcomes than North Yorkshire. We have far higher levels of deprivation than North Yorkshire. I don't think it's equatable at all. On impact assessments, at the end of this agenda item, every single part of the impact assessment is basically blank. I take it, I understand that this isn't a formal decision-making paper, and I know you don't have to, but it would be quite nice if some effort could be made to actually reflect where, particularly on financial, because I think a good pharmacy network that supports the needs of residents will relieve pressure on particular adults. And I think one of the frustrations as a local authority and a unitary local authority is that we spend a lot of money on prevention, and actually the money saved goes to acute. And actually pharmacies is one of the areas where that's not the case, because adults and children save an awful lot of money if we have good pharmacy services, which would save the local authority a lot of money in turn. The ICB and stuff that we talked about in terms of the P&A and everything like that, I know it's not your fault and it's the national process, but I think this is exactly what people find frustrating with NHS bureaucracy. You know, as a resident, you just want your local pharmacy. You don't care what committee it goes to. You don't care what forms need to be filled in. You just want your local pharmacy that's existed for decades, and you don't have, and you don't want the 2-mile walk to the nearest one, or the risk of driving to one which you then get fined for visiting. With that in mind, Chair, I guess I'd like to sort of introduce a recommendation to the paper, because there aren't any recommendations currently, that the committee looks to invite the Minister, Stephen Kinnock, to York to, I guess, look at this situation that we've got, in particular being a sort of pharmacy deserts in parts of York, and what we've heard tonight in terms of some of these national systems not working for York residents. That's it. So sorry, that was a lot of points, but I tried to be brief.
Okay, I don't think you need an answer from the, no, okay. So next, over to Councillor Myers.
Yeah, thank you, Chair. So I've got a brief question which I'll ask, and then I've got some comments if I can come back, and I'd like to second that recommendation and also make some recommendations. So we'll see what committee's appetite for that is in a moment, but I would like to ask Hayley about the needs assessment and the supplementary needs assessment quite clearly shows that Clifton's a pharmacy desert, and it was produced by the council quickly, and they stated through the Health and Wellbeing Board that there's a gap in pharmacy provision in Clifton. I just wanted to ask if you, as a committee, as a board, have ever approved applications before with knowledge of a supplementary P&A, because the example that I could give is that you write a P&A, it's in place for 3 years. If a pharmacy closes at the beginning of that 3-year period, is there no way that the committee can look to grant an application until the next P&A is being written?
So your microphone, sorry.
Sorry, I think if the gap is considered significant, then the guidance is, and I did get some advice before I came, so I knew so I was saying the right thing rather than coming and not saying the right thing. But the vehicle is to write the P&A, but that's not a quick thing. And I know we've talked about sort of, you know, the regulations and the bureaucracy and all of that. I think the P&As are in place for 3 years, and there is that risk. I think historically we've not had the changes that we've had in the last couple of years in terms of community pharmacy. We've had all the Lloyd's changes, then the Boots closures. So actually within the life of these P&As, because it's not just in York but in other areas as well, we have had unprecedented pharmacy changes, and some of those have been closures. The Lloyds it was more positive because there were lots of changes of ownership, which are still changes that Jen said, obviously going in a supplementary statement, but obviously then that means that the pharmacy still stays open, so you're not losing that pharmacy. So I think we've just had an unprecedented amount of change in these ones, and I suppose the positive thing is that they come at the end of the life of them, so that we are starting to kind of write the new ones, and those gaps, if they are, will be reflected in those. And I think because it's, sorry, Peter, because we've had such a lot of closures, we are starting to get some, a number of applications for new pharmacies, and it's new to all of us. We've never had these before because we've never needed them. But it does, the application needs to be robust and assure the committee that it abides by those. And like Peter said, they're not very clear and they're not very concise, but we need to abide by those when we're making the decision.
I mean, just to labour the point really, so you haven't approved applications using supplementary PNAs, you are using current PNAs to make those decisions. So
Yeah.
where pharmacy deserts do appear, that you can't respond to them.
No, the guidance and the regulations say that it's within the current PNA, and that's what you use to make your decision.
Okay. Thank you. I mean, I've got some comments which I'll keep really brief, Chair, and lead towards adding a couple of recommendations, if that's okay. I mean, the decision for my community of Clifton is really shocking, I've got to say. It's the second most deprived ward in York. It is densely populated. Some of our LSOA, low super output areas, are in the highest 10% most deprived in the country, and that they are slap bang in the middle of where this supplementary PNA shows a lack of access to pharmacy services. And so it's really vexing. So I'll leave it there. But I would suggest to the committee, I support Councillor Smalley's recommendation. I wrote some wording which I can put down in front of you. It's very, very brief, but I'll read it out. You pass them down and then I'll pass them over to you. But if members are happy to listen along, and then I'll pass them round. I would propose that the committee is not satisfied that there would not be any improvements or better access by granting this application, that the committee is not satisfied there is a reasonable choice in relating to obtaining pharmaceutical services in the Clifton area, and that the committee is not satisfied that there's no evidence to support innovative approaches to the delivery of pharmaceutical services. And I'd like us to write to the ICB with that as a resolution, but also to write to the council's executive to ask them to urgently review the situation. We could include that in the letter to the government minister, if that is something that members would be happy to. I'll let you review it for a moment, Chair, and then, I'm happy. I'd looking for a seconder.
Yeah. I haven't got one though. Thank you very much. Thank you. I'm not sure that we need to vote on this. I don't. Sorry, but we still do have some other people to speak. If you just, I'm really sorry. Now, hang on a minute, because I'm new as a chair, and I don't know the protocol in accepting the recommendations now or later. I think therefore the end, I would have said, yes. So I think we've all got them. We know what they are. We'll just sit on those for a little while, because we have to hear from 4 more people. I think this is an item that really deserves time given to it. So I don't think anyone is going to be cross about that. Okay, thank you very much, Councillor Mize, and thank you for this. Okay, so Councillor Hook, please.
Thank you, Chair. Yes, I'm represent the ward that's not really shown on this map at all. It is a pharmaceutical desert practically, because in the whole of the ward that goes from virtually Brown's Nursery right across the A64, mostly outside the ring road, a few bits inside, we have one pharmacy, and we are so grateful for that one in Poppleton. But we feel that sometimes we're clinging on by our fingernails because the doctor's surgery only opens half a day. We got the very bad news this week that the Skelton surgery, there's no possibility of it reopening now. The reason why I asked about Tower Court was because all the people from Skelton have to go to Tower Court, and people therefore then complain to me about the fines that they're getting. That's an awful long way. And the other two things I would like to recommend. One is, if you've got a really complicated procedure, can't we institute some way of supporting the people wanting to make the applications so that they don't miss anything on those applications and get a better chance of getting it through? Because most things, someone would hold someone's hand and help you make, like if you're applying for pension credits, someone would hold your hand and say, you've got to do this to do that, and you'll get more chance of getting it. And the other thing is, age has got to pay a consideration, because in the ward that I represent, so many people are really getting old. The number of nonagenarians that you see in my ward are incredible. And these are the people that need an awful lot of medication. And sometimes they need to go and see pharmacies for small things, not always the doctor. And I was so thrilled when the government brought in the thing about using pharmacists for small complaints, because I've been pushing that for ages and say, yeah, talk to a chemist if you've got a sniffle, don't go to the doctor and things like that. And so the residents really want that. But if you've got to travel all the way to Poppleton to get it, when you live in Rougheth, you can't do it. There's no buses directly going there or anything like that. So yeah, but I certainly think you ought to consider age when you consider need, and also consider helping the people doing the applications.
Okay, noted that. Thank you very much for that. Next is Councillor Vassie.
Thank you, Chair. You said in your presentation, Peter, that you didn't want to create an expectation. Well, I do want to create an expectation. My feeling is that unless we properly analyse the service to all residents in the city and the villages, we can't begin to have a strategy. And that applies to Clifton, it applies to the village, it applies across the city. And my recommendation would be that we ask that all future reports, regardless of what national government requirements may or may not be, actually detail the provision of pharmacies to all residents across York. Ben Ockery, the writer, a long time ago, said that about a nation without a dream cannot go anywhere. He was talking about a written constitution. I would say the same thing about strategies. We need to have a strategy for the whole of our city, including its villages, including the areas in the city that don't have anything, because until we have that, we cannot even begin to articulate the world we would like to have, the place we would like to be, the provision that we would like to give people. Like others, I was shocked, about the idea of how far you walk and so on and so forth. One of the things that struck me looking at the report was the implications page on page 28. We've been going on about this around these tables for years now. And this isn't a reflection on any particular officers or anyone in particular. When I look at that implication list, and I don't see a bullet point that says climate change, it sends alarm bells for me, because part of what's going on here is that there are people driving miles in order to get to whatever services they need. We've had the NHS before this committee in the past showing they're working hard to create a climate change strategy. We've had, the City Council has a climate change strategy. How can it be that when we're looking at the provision of services, no one is feeling that there's any obligation to look at it in terms of how far are people travelling to get these services? what's the carbon cost? What's the implication for the future? So I find it shocking that that's still not in our list of implications. In terms of looking positive and looking forwards, we had the integrated care partnership in here before and dentists in here before. And we said to them, would you support the idea of primary care centres in the larger villages, for example, around the city, in order to transform access to primary care? And the integrated care partnership said yes. The dentist said, yes, we'd be happy to be in there. My question, I suppose, relating to all of this is, if we're thinking about a strategy, would officers think that it's useful to look at the possibility of community pharmacies being a part of the creation of primary care centres in communities across the city to address these challenges where we're told the economic model doesn't work? Would it be better for community pharmacies as well as everyone else if we tried to put people in the same building and make the money go further in that way? So I'll stop there on those issues. But it's not just old people, I'd say lastly. Out in the sticks, there are young people as well who don't have access to buses and don't have access to cars. There are young families with, people with mobility problems. So let's not just be fixated on the old.
Okay. Sorry, Peter.
If I may briefly just respond to a couple of those last questions, just I think there's a slight misunderstanding. The report we have in front of us, because it details the last 12 months base of closures, the maps refer to those closures. The pharmaceutical needs assessment, it's a jolly good read. It's 196 pages, and I assure the committee it's got a lot of maps in covering the entirety of York. So every bit of York is fully covered, plus an access to a freely accessible online tool called Shape, where you can draw to your heart's content lots of interesting circles around different areas. So there is plenty of publicly available information around the need that we do use to assess. So just to assure the committee that. In terms of the implications, I fully accept that actually, and Councillor Vassie, I think there is definitely something about thinking about our scrutiny templates as they are, reflecting some executive templates which talk about climate change and other issues, so we can take that back in. I have used that phrase, manage expectations, quite deliberately, because one of the reasons that some of these implication sections are not there is, as a scrutiny committee and thinking about City of York Council's scope of responsibility around pharmacies, obviously we neither commission nor provide them, so it is limited. We can certainly work and very much commit to do so with our ICB partners in thinking about that model for primary care, which includes pharmacy, dentistry, optometry and general practice in rural locations, and actually say to ourselves, for a city like York, it could be very easy to think of itself as a dense urban city, but it includes a number of outlying villages and rural areas in which access is poor. What do we do to transform primary care? And I think that is definitely a conversation we need to have. But I guess the mechanisms we don't have are to pay for any of it as a council, because that is for the NHS to commission. So I'd see our role as supporting partner, and would support any recommendations from the committee for us as supporting partner on that, but just to make sure those recommendations don't become stronger than supporting partner, because ultimately the resource that we have at our disposal as a council doesn't stretch to be able to provide any of those services. Just wanted to clarify that. Thank you.
Okay, thank you. Well, could I, we are really getting very, very brief then.
I do understand that officers have to deal with what is possible. Politicians have to create the world in which new things can be possible, have to bring change to life. And having this access to data, especially if we can get the minister to come and talk with us, is essential to being able to get a sense of what might be possible.
Absolutely, I agree. Councillor Steels-Warshaw.
Thank you, Chair. And thank you for these reports. And thank you, Richard, for the really clear comments showing the essential need for pharmacy provision for people in York. Pharmacies are really crucial in taking pressure off services, the emergency services and the non-emergency services, such as GPs, NHS 111, and the first line of vital treatment for so many people. And as well as acknowledging the ageing population and benefiting from Pharmacy First, anyone who's had a child screaming with an ear infection will also really understand the benefits of Pharmacy First. I had a little play around with a map to see places in Clifton and how far it was to a pharmacy, and the closest was around a mile, and that was a pharmacy that's closed at the weekends. Not all residents in Clifton have pharmacies access to cars to get to the pharmacy, and as Councillor Runciman said, buses are often not able to get you there, especially if you need to be there quickly and you're not feeling very well and you need medication and you're an older person or it's a child. Within this, York has a really transient population who really rely upon pharmacies as a point of medical treatment, really important for them. And to quote Councillor Smalley, I don't think that health is the same in rural areas as it is if we're looking at health inequalities in an inner city area. You can see there's been a reduction in all of the pharmacies and the dates and hours and things that the days and hours that they're open. And again, when we're looking at health inequalities, often people on controlled medications need to attend the pharmacy every single day. And they can't have separate prescriptions to go to separate pharmacies, and they need to go every day. And that can also be putting people in an increasingly vulnerable situation because they're maybe not likely going to go, or if they aren't able to get there that day. And just looking at more negative effects on their health, their well-being. I do believe there is a real need for a pharmacy in Clifton, and would really welcome us looking into this any further, and the recommendations made by Councillor Myers looking at. Thank you.
And Councillor Maroney, please. Finally, you've got your chance.
Thank you, Chair. I'm going to be cheeky and just raise paragraph 24 on page 27, saying I have grave reservations about the Wellbeing Board's lack of objection to a distance selling pharmacy replacing a physical pharmacy. But my main question or point of clarification, if I may, to our expert panel is there a cost implication in reopening a pharmacy in Clifton?
I mean, so pharmacies that like general practice, it's not entirely the same model, but it's a similar model. Operates under that contract. So from that sense, a contractor, and Richard will tell this story much better than I, a contractor operates as a business and has to make enough of the money to cover the overheads of pharmacy, which I gather are going up quite exponentially with the cost of living and inflation and the utility bills, etc. And that will come from a range of sources. Richard's sort of outlined how that's been shifting from the dispensing of the medication into these additional extra services, such as hypertension, case finding, contraception, Pharmacy First. But actually that sort of broad base of pharmacy funding is really dropping out. So the cost implication really is borne, as I think Richard said, by contractors who have that risk and take that risk upon themselves. I don't know, Chair, if it's okay to bring Richard in at that point to offer possibly a more specialist view on this than I can. Is that okay?
Yeah, we have them here.
So the simple answer is no. So previously there was what was called an establishment payment. So every pharmacy in the country was given a certain amount of money each year, £20,000, and then they were funded on every item they dispense prescription wise. That's been phased out now, so there's no establishment payment. So if you've got one pharmacy and a pharmacy opens next door and half the business goes to that pharmacy, and you've got two pharmacies, the cost to the NHS is exactly the same. So opening a pharmacy in Clifton would not increase the cost of running an extra pharmacy. If you mean the cost to the government, there's no extra cost.
Can I come back on that?
Yeah, certainly.
Thank you. I mean, I just think it's very useful clarification, and so it just makes me wonder what the discussion we've had up to this point has been about. I'll leave that hanging. It seems to me there's a very strong case for retaining a physical building that works as a pharmacy, albeit under new management. We all seem to be more or less agreed on that. We've had arguments around how relevant is a 1.5 distance. I don't think we necessarily agree that is the most important part of the debate so far. So I think there is a huge amount of agreement around the room. Thank you.
Okay. Well, one last point thank you, Councillor Morelli and Councillor Rose.
I haven't raised any of my 3 points that I was going to raise at the start, if that's
right,
okay.
yes,
But
sorry.
they're actually questions. I mean, just to respond to that point, I think we are in agreement, and it's the ICB who wasn't in agreement with us. And we'll get to the resolutions. I'm not sure I feel comfortable on a specific application, but something in the unshaded area would be great. But the report is also on the wider situation of community pharmacy. I feel like we've been talking a lot about a couple of specific applications or locations, but I just wanted to ask 3 questions. The first question is broadly, we had a comment earlier about the lack of pharmacies putting pressure onto GPs, urgent emergency departments, and then vice versa. There were comments about the lack of pharmacies, but the government steering 111, etc., pushing work towards pharmacies. I know it references here Pharmacy First. I don't know how much is the Pharmacy First initiative versus just in general encouragement to use them. It'd just be good to get some understanding of whether that is adding pressure to these existing pharmacies over time, and whether those pressures are just people or also financial pressures. A question for anyone. I don't know who's best on each of these questions, by the way.
I mean, Richard again could probably answer, yeah, from a jobbing pharmacist perspective, is that adding to pressure? I would say that part of the general strategy we should be having from a health perspective is to see people closer to home in settings which are most appropriate for them. And we know there was a lot of unnecessary demand in the NHS that we could avert. So I would certainly support us having this. And to answer Councillor Moroni's point specifically, I think we are in agreement. The committee has been on the same page in terms of the opening of pharmacies not having that cost implication. I guess I would say that if 5 pharmacies opened within 100 metres of one another, they would draw upon a single pool of patients and might themselves not be commercially viable. So part of the government's regulations here are about how you regulate a sector, I don't know if that's the right word, but how a private sector is regulated to ensure there's enough competition and enough work to go around within a certain area. So there will always be a balance, and it's not just about cost to taxpayer. It is about the fact that in this country we have this contracted model, not a salary-based model that other countries might have. So I think that plays into it somewhat. Richard, from a pressure perspective, I presume pressure is going up and demand is going up for pharmacy. Is that right? Or is it more complex?
So the population is increasing. The number of patients appearing at the pharmacy is increasing, and the number of pharmacies is decreasing. So use Tower Court as an example, which I've already mentioned, 8,000 prescription items last year, 14,000 prescription items this year. So that has increased the pressure there. And the issue is that because there's not the dispensing margin in dispensing anymore, we're busy doing stuff we're not being remunerated for. What we do is we need the people coming in through the door to do the Pharmacy First consultations, because that then does give the remuneration which pays the staff's wages. So it's if the government were reimbursing us for the dispensing, then we would be able to have a second pharmacist so that we could see much more patients with Pharmacy First. We'll be able to see a lot more patients. But that's not the case. We're kind of running on bare bones and fumes, really. That's the issue.
Just one question, if I may. Are there enough pharmacists out there to run the pharmacies? Because I noticed there's, in-hospital pharmacies and things like that.
So Peter did cover this earlier. So the situation is that Health Education England a few years ago decided, along with the NHS, that it would be a good idea to put community pharmacists into GP practices. Mm-hmm. And what that did, it robbed trained pharmacists from community pharmacy and from hospital and took them into GP practices. So, you know, if you were a community pharmacist and you were working in a community pharmacy, which, you know, a lot of the time it's like a battleground. You've got angry people coming in, angry that they can't get the medicines because there's medicine shortages and there's price hikes. Angry that they're not getting, you know, not getting the medicines that they want and the service that they want. And the pharmacist is dealing with these angry patients, or they can go and work in a GP practice Monday from 9 to 5, sorting out prescriptions. So lots of pharmacists have jumped from community, where it's quite hassly, into GP practices, which has left a shortfall in community pharmacy. So that what that's done is it's meant that the wages have gone up, and we're having to employ more locums to come in on a temporary basis. So we haven't got the same established staff. So, you know, and that's going to take years. If pharmacy degree is 5 years long, it's going to take a long time for that to actually catch up.
Yes, I think another recommendation from the minister, but thank you.
Yeah, second question.
Oh, right.
It's a short answer though, I think this one, which is, in terms of capacity pressures, we've also got developments with large housing numbers that are being built, and we had one that I was present at last month where the ICB got £165,000 of health Section 106 output from it. I'm just wanting to validate that the only way that will actually make an impact on pharmacy aspects is if that then updates the PNA to say there's a new area with lots of people in it. And to be fair, over the course of development of housing, it probably won't be 6 months, so it might be in the next one anyway. But that is the only mechanism by which additional population pressures could lead to extra pharmacy supply.
I think so, but I actually would have to check on that if Section 106 has ever been used to pay for capital for pharmacy. I'm not convinced it has been. I don't think it has been locally, but we could check on that, Councillor Rose, because I'm not entirely sure. And it's a very good point, because we are doing a lot of work around health infrastructure with 30,000 new houses, etc. And we do need to make sure that's not just primary care, general practice, but it is the other aspects of primary care.
Yeah, it'd be good to get, I guess, clarity in general on the Section 106 and how it impacts pharmacies, GPs, the hospital pressures, anything else that impacts health. What can we ask for, and what's the appropriate thing to ask for? Final question is a broader question, but I think an important one. A lot of this stuff is longer term. Can we perhaps change the law to actually enable us to do what we want to do in this situation, etc.? Thinking about this winter specifically and the capacity pressures we've got here, obviously, you know, people are aware of stories in the news around heating decisions, and part of that is the cost of living going up, bills going up, etc. We've also obviously not had an increase in flu and COVID vaccinations lined up or anything like that. The critical role that pharmacies play in vaccination and in treating people with those kinds of illnesses. What does it look like this winter in general for health in the city, for those sorts of conditions, for GP, for waiting times, all that sort of stuff? Is there anything specifically in pharmacy world here that we should be really concerned about this winter, or is it business as usual, or you know, outside of this one gap, more broadly, how are we feeling?
What the committee's getting a paper in November, which I do appreciate, is we're into winter then, aren't we? Which is going to be talking a little bit about winter and sort of health protection sort of issues. But I would say at this point we've now got a third jab to add to our sort of arsenal around respiratory infections with the respiratory syncytial virus RSV jab, which is opportunistic in pregnancy and really important at that point in terms of maternity services. But outside of that, it's also for older folk, and then COVID and flu. And I won't make an attempt to do the eligibility criteria for those who get it wrong, but there are eligibility criteria categories still, and getting those who are eligible jab this winter and through pharmacy routes, often the most popular, the easiest, certainly the route I've chosen myself in the past, is absolutely essential. It's a thing we can do that is already funded and out there to protect the health of the population in a cold snap. So let's do it. That's my public health message of the day.
Okay. Right, well, thank you so much for coming along and speaking to us and answering all our questions this evening. It's been a very comprehensive discussion, which I think was needed. I think this is a major issue. I take it, you know, I take the thing about North Yorkshire. We've got more than North Yorkshire, but I think we've got to look at what's happening here as well, and all the implications with urban living that are quite different. So we have here a list of recommendations, and I've added some others to it. If I haven't remembered yours, apologies, but I've done my best. So Councillor Myers has given us this sheet. I don't think I need to read it out, or do I need to read it out for protocol? Okay. Yes.
If I could just clarify the first sentence, it refers to granting this application. Councillor Rose quite rightly mentions to me that it should read these applications.
Yes.
Yep.
Yeah. These applications.
But I've read it out once, Chair, so it's on the record.
Okay.
And
Thank
Yep.
you for that. Right, so Councillor Hook mentioned, can we support applications in areas that have a lack of pharmacies? I know that you think it's a bit out of our control, but we have to dream. I do agree. Is there any harm in doing that? We're supporting those applications at least. We don't want to make a division between town and village. Villages are just as important in York to us as the town is. Councillor Vassy, or ports need a strategy for towns and cities. There you are. That's and travel and carbon costs need to be thought about as well. Travel wise, I would struggle to walk a mile. So, if you order a taxi and you're a wheelchair user, you have to usually give 24 hours notice in York. So if you've got something acute, you're stuffed really. Primary care facilities needed in villages. Again, it's here we are dreaming, but let's dream a bit. And they could be primary care facilities shared with dentists, optometry, physiotherapy, occupational therapy. Maybe they wouldn't be there every single day, but why not? Let's recommend that. And we did also recommend, Councillor Smalley recommended inviting Stephen Kinnett to come and look at the situation. Why not? One other thing that I thought of, because what puzzles me is the P&A is in place for 3 years and it's updated, but then it wasn't looked, the update wasn't considered. I think they need to be updated much more frequently, maybe monthly, and they need to be, that part needs to be taken into consideration. Sorry.
Thanks, Chair. And I have to admit, I also share a nagging question now for this session, which is, I'm not sure, and I'm responsible for it, what the point of the supplementary statement actually is, if it can't be taken into account. That seems to be where we've got to. So for me, that is more the issue. I will make a plea around our team's resources and the amount of resource that has to go into doing it every 3 years, and obviously there are implications for doing it more regularly, and getting a mechanism where you can have supplementary statements during the course, which generally don't take a particular lot of officer time and don't need that extra public consultation, etc., that takes the time, would seem to be the right mechanism. But then if it can't be taken into regard, what is the point of it? So I don't know whether that's part of our communication with government in terms of an ask for clarity on that for both us and for RCB colleagues, in terms of if there was a statement that says ICB can take it into account, that might change the situation we find ourselves in. So before going into a more regular review of the P&A, I wonder if we could go down that road first of trying to establish how we use supplementary statements. Perhaps it could be a letter from me as the DBH to Department of Social Care, or could be to the Minister from a political perspective. I don't really mind which, but one of those two might be the right route.
Or both, yeah. Councillor Hook.
Yeah, I think you wrote down my recommendation. It wasn't what I wanted to say. I wanted to say that when a chemist was making an application to put in a pharmacy, a pharmacist was putting an application to open one, that someone really helped him do it.
Oh, yes.
Her,
Sorry,
so
yes,
that's what I
yes.
meant. So
yes, support, yes.
So that you filled in all the things and didn't miss
Yeah.
out a crucial thing that meant that your claim failed.
Yeah, for all applicants, we're not.
And that's absolutely crucial point, Chair, for me, if that's okay. I just would want to make sure, obviously, I mean, what we've got here is 3 applications within a certain geographical space. And to be clear, those are 3 competitors who want a bit of a market in some senses. So we have to make sure our role within this is clear. What I guess we might consider is what our P&A or perhaps the website it appears on may have contact details to speak to the public health team around, and I'd have to seek a bit of advice on this, but I could see a situation where we could offer communication in terms of interpreting our pharmaceutical needs assessment or any clarity that someone might want to have on it. That I don't think would go across the line into helping it, would be an open offer to help the public with something that is a public document. That might sort of fulfill that requirement, Councillor Hook, around making sure that people have the right knowledge at their fingertips when they're writing these applications and there aren't sort of misunderstandings about what's written. I don't think that's necessarily the case with these, but that might be the sort of level of support that we could offer. I guess what we can't do is act with one sort of applicant when there may be 2 or 3 others that didn't know that offer was available. So having something open to all is the route we need to go down.
So, right, Councillor Rose, very brief.
Yeah, it was my point was going to be backing everything that that Peter's then said around when we're talking to the minister and hopefully bringing the minister here, but when we're communicating, making the point that the legal levelling should include the supplementary and not just the primary plan.
Absolutely.
But also the point that you've just raised, Chair, about taxis, where we have the ability to manage Hackney carriage accessibility needs, and we have the ability to have a taxi licensing policy for those that we license here in York around wheelchair access and other situations. We have a big gap legally in our ability to manage out of town drivers. That means we have a lack of provision of taxis you can phone up and get access to if you have accessibility needs. And that doesn't just have consequences for the ability to go and hang out with your mates, it has an ability to get access to healthcare. So I think it'd be really important to raise that with the minister as well as part of this problem, but as part of a wider problem as well.
Good. We're being very comprehensive tonight. Right, so with that in mind, I think I've covered everything, I hope. And there was a proposer, a seconder. I don't think we need to vote on this. I think we're unanimous on this, looking around the table. Yeah. Yeah. Okay. So thanks everyone very much. It's now 7:10 and I propose a 10-minute break before we go into the next. So back here by 20 past. Okay. So welcome back to the second half of this Health, Housing, Adult Social Care Scrutiny Committee. We're moving on now to the item 5 on the agenda, which is Homelessness Future Resettlement Pathway. And we have Pauline Stutchfield, sorry, Pauline, Director of Housing and Communities, Dennis Southall, Head of Housing Management and Housing Options, Andrew Bennington, who is Housing Strategy Officer, and we are also joined by Councillors Pavlovic and Councillor Steele-Warshaw. Councillor Pavlovic covers housing, and Councillor Steele-Warshaw covers health, wellbeing, and adult social care. Thank you. Okay, so I'll put it over to you to present this paper. Thank you.
Thank you, Chair. This committee considered this report on resettlement pathways for those over the age of 16 in York who found themselves homeless at its committee on the in June. This report is from the 9th of May executive meeting, which made several decisions to reshape the delivery of homelessness resettlement services. The discussion around the report at the June committee was deferred to this meeting. The executive report talks about the first stage of the process bringing in existing services in-house. The second stage of the process would ensure the council could provide a variety of effective, flexible accommodation and support solutions for residents who found themselves homeless. And then it also talked about the strategy, which I'll come to shortly. So just to give you an update of what's happened since May, work is underway to bring in-house the community wellbeing resettlement services currently run by Changing Lives, including the operation of the single persons hostel at Union Terrace and the women's only hostel at Robinson Court. The transfer of services will take place on 30th of November. It was in the interests of all parties, but not at least the interests of residents, to make sure we didn't leave that transfer until December and over the Christmas period. Approximately 45 staff will transfer and become council employed as part of that process. And as part of the transfer, accommodation services in shared housing will also move across. And this part of the service supports and prepares individuals with the skills needed to hold a permanent tenancy. There's a number of council properties involved, also properties owned by Joseph Rowntree Housing Trust and properties owned by Changing Lives. Those properties owned by Changing Lives are going to be retained by them. The report also talked about the new homelessness and rough sleeper strategy, which will replace the homelessness strategy 2018 to 2023. The strategy will take a housing first approach for single homelessness clients, focusing on the rapid rehousing of those facing homelessness, ideally avoiding time in a hotel or temporary accommodation. Where an individual or family needs help to establish and maintain their tenancy, we'll support them through the delivery of cross-agency support services, which will sit very close to the service on a multi-agency basis. We will give attention to the specific needs of disabled people. We will work to prevent rough sleeping and tackle domestic abuse. We will work with partners to develop and sustain services which will achieve these goals. Clearly, the supply of suitable and affordable homes is key to the success of the strategy, alongside the prevention of homelessness and keeping people in their own homes where possible. We will take action, harness resources and work in partnership to make more homes available. So that obviously is a draft strategy, and our aim over the next couple of months is to engage widely, starting with partners over the next couple of weeks on the draft priorities in the strategy, which was talked about in the May report, but has actually extended to now 7 priorities, which I'll not go through in detail here, but I would like to discuss with the committee how Scrutiny Committee wants to engage with being consulted on those priorities in order to inform an executive report to December executive. I'm advised that there may not be an appropriate set meeting to have those discussions in terms of timing. So members may want to consider whether they have an additional meeting or a task and finish meeting to discuss those priorities. So I think that's it, unless officers have got anything to add, but we're more than happy to answer any questions on any of those items. Thank you.
Much for that, Councillor Rose.
Thank you, and thank you for this paper, and thank you for the previous paper you brought, and apologies that we couldn't discuss it in full at the time. It looks really good, and I'm very pleased at the direction of travel to include, you know, a lot of best practice, modern practice that historically speaking we haven't been able to do or haven't done. The specific question I've got and that I wanted to ask in more detail at the time was, there's a lot of references to third parties here. We've obviously got things like, for example, the reference on page 43 to Robertson Court going from 64% down to 32% over 2 years. On here, we've got references to SASH and other organisations as part of this structure. Long term, our relationship with these third parties and partners, what's the general plan for the direction of travel on this? Is the intention to identify where we are not best suited and to continue to find the best partner for that gap? Or is it to look at the best partners that we have and build around them? Or how do we work out which bits the council should do and which bits should be third sector, if that makes sense?
Thank you for that. So I think the response is it's built into the strategic approach. So it will be everything from the current consultations that we've arranged over the next few weeks with partners, some of which are bespoke with organisations that are close to the resettlement pathways in particular, and then some open sessions over the next couple of weeks as well, which organisations are being invited to. And for those that can't attend, we'll be sharing the strategy and the sort of structured questions that we have for them to be able to respond to. Going forward, part of the strategy means that we set up a strategic governance structure, which we've not had previously, and which I think will drive forward that partnership, working at a very high level strategic, so across health, housing, probation, police, etc. So that's already in hand. We've got the first meeting in the diary for that, ahead of the formal strategy being adopted, to talk to partners. And on an ongoing basis, we continue to maintain and develop relationships with existing charities within the city and other organisations as well. Obviously, part of this is around development. So everything from, you know, the work that we do around creating affordable housing in the city and purchasing that, through to the other strategic approach that the council has taken around the locality models as well, because as well as the core services that we will provide as a council, we need a whole range of wraparound services for individuals through their journey, ideally preventing them coming into homelessness services, but once they're in there, getting them through as rapidly and as appropriately as possible. We can't do that alone. We absolutely acknowledge that, and we need a wraparound team that's at the core of the offer that we have in the city, but again, out into communities, working intensively with services like pharmacies, GPs, local area coordination, that sort of thing. That's all part of the strategic approach that we're talking about. And what you haven't got today is the consultation documents that we've put together, which would be hopefully going to that session that Pauline's highlighted that we want to do with you. So there'll be a lot more detail on that, and potentially we'll have had some feedback from the sessions as well that we can potentially feed into that. So it's absolutely embedded in everything that we do. We continue to have ongoing meetings with Changing Lives, for example, on a weekly basis at the moment, and with organisations like the Salvation Army, which we have a slightly different relationship with now, but are very much part of the wider offer, particularly around meaningful activities and things like that, for the people that come into contact with our services.
So a mini additional is that sounds really good, and thank you. And obviously it is a key part of providing a world-class homelessness service and the other facets of the service. Are those conversations mostly geared towards what is currently there and what we can do better and tweak, or is it also looking sort of 3 years down the line at what's developing for them as organisations, for us as a council, but also best practice needs? How does this work in terms of regular checkpoints with multiple partners, etc.?
Yeah, it's very, very much that. So, for example, we want there are a couple of examples. One, a lot of this work is based on a paper that the university, the Centre for Housing Policy at the university, which we have a long-standing relationship with, is put together based on best practice from around the world and our own experiences and knowledge of that as well. And we want them to be absolutely integral into monitoring that in the future, our performance, and helping us develop that as well. So that relationship will be entwined in the work that we do going forward. There's another piece of research going on with Tanghall Smart and another area of the university about the sort of gaps in homelessness services and the experience that people have going through services as well. And some of the feedback is quite robust, shall we say, for us to hear. But that's the sort of feedback that we want. We want open and honest feedback from independent sources like this. So it's an independent piece of research of which we're contributing to. But we want to continue those sorts of relationships and challenges within that, so that we can genuinely listen to the third sector, other organisations, most importantly, the people who experience our services, so that we can, with the resources that we've got, become better and deliver for them. So they're very much at the heart of that. And it is about listening and working with other organisations. We can provide the core services, which is a decision that the executive has taken, but that is a very small part of the overall picture that we want to create for people experiencing homelessness and rough sleep.
Councillor Moroney, and then Councillor Runciman. I'm sorry. Okay.
Thank you, Chair. I'd like to start by saying I find this all very exciting and not before its time. So thank you for coming along this evening to talk through it. I'd like to pick up one point, if I may, which is made in paragraph 46 on page 46 and paragraph 61.5 on page 50, both talking about this temporary project team from within existing budgets. Okay, so I suppose I'm seeking a little reassurance that, given how stretched the council is with all resources, is there really the capacity to suck people out of other other projects, and will it be resourced enough to actually deliver this extremely complex piece of work? Thank you.
Yes, it is being resourced. So we've got a project manager in specifically to drive this through, which is proving very successful. I have to say, it keeps us on our toes. We have, as I've said, well, I think we've had 4 meetings today on this topic alone. So it does take up a lot of our time, but it's being driven through by that project manager who's a very experienced person who knows York very, very well and is doing a great job in my opinion. Oversight by Pauline here on a weekly basis as well. So yes, the resource has been put in to deliver this because yes, you're absolutely right, we would have struggled with that. But that was picked up early and was agreed and is in place and has been for some time.
Thank you, Chair. Just to add, our timescales were partly determined by the availability and the statutory requirements of HR support around the 2P regulations as well to allow sufficient time for that to take place. And we have the HR support to be able to do that in time. It's absolutely critical that that's done very carefully and along with the staff involved.
Thank you.
Councillor Runciman.
Thank you for the report. I've got 2 rather unrelated questions. So if I can ask one, then you answer and I'll ask the second. The first one is about the young homelessness. Alarm bells rang when I realised that Ofsted was involved. I can't think why that should be, but it does. So I want to know if you see any problems or you know of any problems that may have happened when you tell people they've got to be registered and inspected by Ofsted. That's the first question.
It's certainly a consideration and it's one that we have been aware of and again is built into the model going forward. So laid out in some of the papers that are annexes to this paper today, you will find reference to those issues. We have an integral relationship with children's services around youth homelessness. We have protocols in place for care leavers and homeless 16 and 17-year-olds. We work with the responsible manager for registering the properties, and we will be developing a specific site at Scarcroft Road, which will be a registered site for homeless 16 and 17-year-olds. So that is built into the development of the pathway going forward. At the moment, we're managing those responsibilities between our teams with the current buildings and staffing that we have.
Just an additional comment. My particular worry was Sash, because these are people's private homes. And the only other instance I can think of something similar is registering childminders, which is a slightly different thing. So I'll ask my second question, which is the current situation with the discharge, the early discharge of prisoners. Are you expecting, thinking about planning for an increase in homelessness and demand for your services?
Councillor Pavlovic might want to answer that, I think.
Thank you, Councillor Runciman. Just on the Ofsted issue, the previous government changed the regulations, which meant that Hal Hill, for example, then had to become registered because it had 16 and 17-year-olds. So that was in essence forced upon us. Yes, we've had meetings with the probation service, who were given several weeks' notice of expected numbers in York, and it's incredibly small, less than the fingers of one hand. And of those that are being released early, the majority of them had accommodation to go to, so they weren't coming into homelessness services. And the ones that were, of whom, you know, literally 1 or 2, we've been able to accommodate from within our existing resources. So, and our last meeting with probation was, what was it, last week? Last week, yeah.
It's good to hear that, and I hope we'll have an update on that, because obviously that early discharge is going to continue. So we will only know bit by bit, won't we?
Yeah, I mean, it was one of the big concerns that we had once it was announced. I mean, when it was announced previously, it was an issue, and then when it was clear that there was going to be this September discharge, we had very, very early meetings just to determine, you know, how big an issue was it going to be? Was it, you know, were we going to be talking in the dozens for York? And thankfully, because they gave them the probation service were given a preliminary list of who was going to be released, we were able to then extrapolate it out. So yeah, there's been a number of meetings with colleagues in criminal justice.
Okay, councillor Vassie then comes this morning. Thank you.
Thank you, Chair, and thank you for the report. You mentioned the issue of partners having working with partners going forward across the city. My question really is, how are we to feel confident that partners in the city will have confidence in the city council, given all the problems over the past year? What has been learned from the experience of the past year? So that everyone around the table is aware, if you're not already aware, Audit and Governance considered a report on the relationship between the City Council and Salvation Army in August. A number of questions were raised there, and there was a good exchange between the committee and officers. But there are a number of points that were suggested needed looking at, including procurement rules and waivers and service reviews, the gaps in the contract, transiting of services, ownership of decisions, procurement method, well, I've mentioned procurement, training, communication between the parties.
Could I just...
The point of my question is this. What I want to understand, because in order for these two options to be properly considered, I think we need to have confidence going forwards that the lessons from last year have been learned, that we're going to be moving forwards in a different way, that contracts will be done differently. So I'd like to just hear
answer that, yeah.
how that's going to work.
Thank you, Chair. The items from Audit and Governance Committee are all in relation to process and procedure, and there were a set of agreed actions coming out of that meeting, which includes a review of contract management across the council, including the Salvation Army report. So that's that backward look and assurance that lessons will be learned. And I think you heard from officers that evening that lessons had been learned and will be learned going forward. In terms of our relationship with partners, that work has been ongoing to continue to work with partners on the strategy. We've got the sessions coming up in the next couple of weeks. It will be a mixed economy going forward, just referring to the previous councillor's question. So, for example, the SASH contract has been relet and renewed with SASH, and our partners are absolutely integral to the wraparound service. So our residents currently have to touch on lots of different processes and touch points as part of their journey. And having been on the Poverty Truth Commission, I've heard that firsthand from people about those touch points. What we want to do is bring that together in a way that we can early intervene together in partnership, working closely together. So it's absolutely critical that we work as one city and that we don't work as separate organisations. So learning all of those lessons around partnership working is key. We have one-to-one meetings planned with both Salvation Army and Changing Lives. They're going to be part of the group sessions going forward. We absolutely want them to be part of the future and to see themselves as part of the strategy going forward. The high level monitoring of this will take place at the partnership group chaired by Sarah Story. So it's not the homelessness team monitoring themselves, it'll be cross-organisational, citywide partnership that will monitor the success of this strategy. And that will be evaluated and monitored by the university. Hopefully that's not finalised yet, but we're having those discussions as we speak. So hopefully you'll get that there's more transparency, if you like, and monitoring going forward at the highest levels across the city.
Can I quickly respond? Just make sure I've understood you correctly. You said there's going to be an outside body monitoring all of this. Is that?
It's a partnership body.
A partnership body.
And it's going to report to the Health and Wellbeing Board, I think. Is that? Sorry? Sorry, the ICB, the place board. So that will report in to the ICB board, which again is multi-partner, multi-agency.
Okay, thank you.
Thank you. Councillor Smalley. Thank you.
So I've been called much worse. Yeah, very recently. Yeah. Daily, it's a daily thing. I guess I've got two questions. One that's hopefully really quick. A very thorough equality impact assessment. So going on to the previous, what I mentioned in the previous session, really good to see. I guess the mitigation sort of constantly highlighted, I guess, against every protected characteristic refers to the new data-led performance framework. I just wondered, I guess, is that ready? Is that live? I guess given that's a significant mitigation, where is that?
So that's in development. So we're working with partners, but we're doing some core work with business intelligence colleagues to develop a set of deep dive data around the whole system. But looking at its constituent parts as well. Obviously, we've got historical data from the research that we've done in the past. So as well as sort of, the traditional numbers and the data that we have to return to government through statutory returns, we are developing, in the process of developing those more local, qualitative bits of information, as well as the quantitative ones as well. So in addition to that, we'll hopefully engage with not only organisations like the university, but also partners like Life, who give us real quality feedback from people who've experienced those pathways as well. So it's not just about numbers and statistics, it's about how people feel and the experiences they've had as well. And we have done some of that already. So it's developing, it's emerging. It's not the final product by any stretch of the imagination. I think Councillor Pavlovich will be able to say that even during his time in this role, the information available has developed fairly considerably, so that we've got real-time data on across the service, but it's still not enough. We still need to develop that as well, and it needs to be open, transparent, available for everybody to see, not only for the strategic board and operational staff, but the general public and wider councillors, etc.
Yeah, thank you, and thank you, Chair, and thank you, Councillor Smalley. You may recall right from the outset of this iteration of the committee that I made a commitment that we would change the transparency. So, for example, the homelessness and rough sleeper numbers are published on a monthly basis now, as opposed to relying on the ones that were officially submitted in November to government. it is absolutely crucial that performance and contract management, even if it's being delivered in-house, is incredibly robust. One of the reasons is, you know, if you want people to progress with their lives and move forward in the directions with the hopes and aspirations that they have for themselves, you've got to measure how successfully you're doing that. And that's where Dennis is right. It's not just about statistics and raw data, but statistics and raw data are really important. And that's one of the reasons why we want an independent evaluation. And as I say, you know, hopefully it will be the Centre for Housing policy. But if, you know, if for some reason they can't do it, we will look to find somebody that can independently and robustly evaluate whether housing, we know that internationally housing first makes a massive difference. We know that rapid rehousing, which, so, you know, we're looking at rapid rehousing as well as housing first. Housing first is a specific model, as you will know, and it's got a distinct set of criteria around the wraparound support. Not everybody needs that level of wraparound support. It's about effective triage. It's about how that triage works. It's about that needs analysis. It's about developing a package that's there designed around the individual, not around what we can offer and how do you fit into that. It's around what are your needs, what are your support needs, and then putting that package in place for as long as it's needed. And for some people, it will be a lot, and it will be multi-agency, and it will be multidisciplinary, and it will be complex, and it will go on for a very long time. For others, it will be around what was historically called floating support. Helping people to set themselves up in a tenancy, helping themselves register with a GP and a doctor, helping themselves apply for benefits, finding useful activities. That will be the support package, and that will be delivered. Could be delivered in-house. It could be delivered by an external agency. So those are the things, but we need to then evaluate how those individuals are doing, because what we're trying to avoid is what we've seen for the last 30 years, which is that revolving door of homelessness, failure, moving into services, moving out of services, moving back into institutional care of whatever that might be. It might be health, it might be criminal justice. It might be back into the sector. We've got to break that, and there is a different model, and there is a better model, and that's what we're introducing. And excitingly, you know, talking to people with lived experience, and Dennis has mentioned, you know, we've been talking with the sector. They think this is the right way to go. You know, if they had a wish list of things that would have helped them when they were in the system, you know, these are the things that we're actually delivering. So I'm really looking forward to Friday's conference, and I genuinely want it to be a co-design, and I want you all to be part of that co-design process. And that's why Pauline's already mentioned, you know, we do want to know how you want to engage with this moving forward. Yeah, that's pretty much it.
Okay, thank you. Supplementary, Kansas.
Yeah, well, my second question, I mean, that was incredibly thorough. No, it was all very good, and obviously agree with what you've said. My second question, I guess, came from the answer to Councillor Vassey's query, and I think, you know, I don't doubt at all the executive member's commitment to ending rough sleeping. I think, you know, you were incredibly clear at the start of your tenure in terms of your ambition. I guess that makes it even even worse that the council handled this area so sort of calamitously, in terms of the original decision, the communication around that decision, the review of that decision, meetings, papers getting pulled, meetings getting pulled, etc. So I guess
off topic.
it's not. My question, the answer to Councillor Vassy was talking about future relationships with city partners. I guess we've just had this review of the 2018 to 2023 homelessness strategy, and obviously now we've got this resettlement pathway. I guess what engagement did key partners have in that process in terms of the review and coming up with a strategy, and explicitly, I guess, were the Salvation Army involved as a sort of key partner in this area? And I guess I've just done a quick Google, and there's 20 news articles mentioning City of York Council and Salvation Army, all of them negative in the last 12 months.
This is just,
so I think
we're straying very much off topic from this.
From a senior management level, I guess, and this is probably to Pauline or Councillor Pavlovich, have you had sort of one-to-ones with the national leads at the Salvation Army, regional leads at the Salvation Army, just to reassure that we're still committed to working with them?
I think you're in another meeting, to be honest, but
I've got a short answer to that. Yes, I've met with the regional director and with the assistant director responsible for the local service. So yes, it was important that we did that.
Okay, thank you. Councillor Rose.
Thank you. And yeah, my point was originally going to be a much calmer point about Christian's point around the historicity of it, and just correcting that you mentioned last year, but just to outlay the long list of things ANG had gripes about included some issues from last year around, for example, what happens when someone's on leave. It included some things from the last administration, including procurement, communications there, but it also included the previous administration to that when the contract was written, service reviews. So we're talking many, many years of issues. I take a slightly stronger issue with what Darryl said since then of trying to lay the blame here when audit and governance and everybody found that the main problem happened at an executive meeting where he was personally present, and most of these articles came about when he decided to write a press release off the back of this meeting that contained falsehoods on it. But the point I want to make is that the lessons learnt on that when it comes to the scrutiny and for the homelessness side of things have clearly evidently been learned. They're embedded within this document. We've got the learning to actually engage with the people who use the services and have in the past used those services and been through the process, if you like to call it, or pathways. It includes working with those partners and making sure we have ongoing regular communication, not just point in time occasional communication that eliminates some of those issues. And it includes a lot of other things that helps make sure this is strategic and long term, and the specific issues around contracts, around procurement, around some of those officer communications or what happens when people are away and so on. These aren't just unique to this particular either contract or to homelessness in general. It's a service management issue broadly across the council, and audit and governance have, I think, what was it, 8 or 9 actions we ended up with that are going away, specific threads where they're going to come back to audit and governance until the committee is satisfied that we are definitely doing re-procurement properly, that we are evidencing when we're bringing something in-house, that it is better than if we went out to market. All those challenges, I think that they're going down the right path. But can we lay to bed things that are looking backwards when this committee shouldn't be doing that? And can we make sure we're not just repeating things we know aren't true on public record? It is not helpful. Thanks, Chair.
Thank you. Councillor Pavlovich.
Yeah, and you'll see from the strategy, and I'm very much into looking forward, but what is best practice that may be different to what has happened in the past. So, for example, we are talking to people with lived experience. We are talking to people in the sector. We are engaging with them. We genuinely want their input and opinion. You know, there is not one I know everything, or the council knows everything, and it will design the perfect model. Because had we done that, we would have addressed things by now, and we wouldn't have homelessness, and we wouldn't have had, you know, we'd had a completely different system in 2016 when it was reprocured. You know, people people miscalculate, if you like, and going back 2, 3, 4 administrations, you know, and then those mistakes get perpetuated. Will we get everything right? I would love to think yes, we are, and yes, we will. But there's a chance that things won't go perfectly. There is in every single strategy, every single system that you try to introduce, you do the best that you can. And how do we do the best that we can? It's we talk to as many people as we can. We engage with as many organisations as we can. We get the experience of those people who've got lived experience. We put contract management at the core of what we're doing. And good evaluation with really strong support plans for the individuals that you can then subsequently measure. So that's the only answer I can sort of give you as to the commitment moving forward of how we want to try to get this right, because getting it right actually improves people's lives. Getting it wrong has a negative consequence. And we want to help as many people as we possibly can.
Thank you. Right, no more questions. I think we need to look at when we're going to have the either a task and finish group on this, or whether we're going to bring this back at a future date with an extra meeting. Sorry, Councillor Vassy. Okay.
And to respond to what you just said, Councillor Rose.
Microphone, sorry.
To respond to what you just said, Councillor Rose, yes, I agree with a lot of what you've just said there. And the key is that we either learn from the mistakes of history or we're condemned to repeating them. And you're right, they point to systemic challenges that go back a long time. My question really is to further understand what you've said about the independent overview of this. And I should say, you know, all of us around the table share the belief that this is an incredibly important topic, dealing with the most vulnerable people in York, and want to see it succeed. My question is the independent body that's going to be looking at the service provision and everything else also going to be looking at the contracts that are drawn up and helping to advise on them? Because it was something that came up in the meeting that Councillor Rose and I attended. And it's not restricted to this area, as you say, Councillor Rose, that there were things in the contract that should have been seen and weren't seen. And when you bring everything in-house, there's a risk that that becomes harder. And actually, this is a great opportunity if there's an independent advisory panel or body. Are they going to be looking at contracts to make sure that they achieve everything that Councillor Pavlovic has said he wants to achieve? And I think we'd support what he wants to achieve.
There's going to be two elements of the governance process. One is an operational board chaired by, I think, yourself, and then the strategic board, which will be a partnership board chaired by Sarah Story, as I mentioned earlier, reporting into the ICB. They won't be looking at detailed contracts now. It will be our responsibility as senior managers of the council to make sure we comply with the financial and contractual regulations that we discussed at Audit and Governance Committee going forward. But the effectiveness, the outputs, the outcomes of the work that's going on will be monitored by the strategic board to ensure that it's all working, and you know, challenging that and seeking to make sure that if things are slipping back, that improvements are put in place. So it will be monitoring and improvement planning.
Okay. Thank you. Right. So I think
it's a proposal of what you actually asked for, Chair, if that's okay, which is that I think that a task and finish group working every week on this and working through it doesn't seem like the best use of time when I think there is wide interest in this. And you know, things like the transition of the contract at the end of November, that's the one that's expiring, that's referenced in this contract. I think it's seeing the consequence and the impact of that as it comes through through the year. The question I've got is work plan wise is, are we still keeping them separate as adult social care housing where we can, and if so, which one does this fit under?
Good question.
But my broad suggestion would be that January feels like a good meeting to bring us back to see the early impact of the changes we've got on here. But I welcome views from others.
Right. I have got a list of issues with the forward plan, the work plan, that James kindly left because he's been liaising with officers. So I think that we can combine that briefly with this. I don't know if we need to have you here still, because actually that's going to be the nitty-gritty of our work plan, rather than if everyone agrees that it would be better to come back rather than have a task and finish group, which I do agree with you. Sorry, I'm jumping the gun. It's getting late. I don't know what people feel about a task and finish group, basically, compared to having another meeting with updates on this. Anybody got any ideas? Councillor Pavlovic.
Given that there is a report got to go to executive for decision in December, kind of what I was really hoping, and you know, it's absolutely in your gift and up to you, was I was really hoping that a subcommittee or a group or all of you would meet to consider the proposals in detail and feed back to us, so that when the actual detailed strategy proposal comes to exec in December, it's had your input. I just think if it comes to November to January, Councillor Rose, it's kind of already done, and you then won't have had the input that I was really hoping Scrutiny would be able to have.
So what's the appetite for having an extra meeting between now? What date in December is
beginning of?
Beginning.
9th, I think, 9th,
so it's
10th, something like that.
We're going to be looking at November.
Yeah, but don't forget the papers have to be published beforehand and then it has to be written.
Yeah.
I mean, realistically, if you were able, I mean, it doesn't have to be a public meeting. It can be just a subcommittee meeting where a group of you get together and just feed in. Sometime in an ideal world, October is what I was hoping, because we should have quite a bit more meat
by October. Could we say
October?
Late October?
Sorry, I'm saying October without looking at my colleagues here.
I'm just, I mean, we'd have to sort of confer with people's diaries. Late October? How do people feel about having either a subcommittee or yeah? I can't. Councillor Smalley and Councillor Wong. You'll go with the flow. Okay, very good. Over there's a great deal of looking in.
I won't be around, Chair, for the last 10 days of October. Just so
you won't be around. Okay,
I'm away.
Okay. I think I need to confer with the democracy officer and find a date, and that most of us can get to, in order that want to be on the subcommittee. I think it'll be very valuable. It's obviously wanted. So, and I think we're going to have to fit another meeting in. I think the only space that we've got is in January, and even then, that's to be confirmed. A report coming to us.
I think given the points made, it does make sense to have at least optional for people to feed into that process before December, whether we have a full committee or subcommittee or whatever. Looking at the council calendar rather than my own diary, the week of half term doesn't have many council meetings in it, but the week before and after have quite a lot of meetings in it. So that end of October, both directions, the further you get from the end of October, the better it is. So I think it probably is worth taking offline to liaison who can be invited and how many
Absolutely.
people is
Yeah,
best.
we're not going to pin a date down right now, I don't think.
Agree, and just to suggest we could always look at virtual meeting if it's not a formal council committee. That'd be a lot
As long
easier.
as long as that's allowed, yeah, yeah. Right, okay. So thank you all very, very much for coming along. Right, so our final part, sorry, of the work plan. So we've got the work plan here. Has anybody got any comments on it? No comments on the work plan, councillor Rose?
Yeah, I'll kick the conversation off. It comes back, I know, as per to the first question, which is, are we definitely keen on having this rotation where things don't necessarily fit in the right month, and we end up with, at the moment, a blank January, but then we've got a packed another month because of how it falls? Or is, especially given that we have both exec here this evening, are we actually finding ourselves in a bit of a challenge? So the first point is, I think in general, we need to consider health and housing, health and everything to do with health, housing and everything to do with housing and homelessness and voids, etc., is a huge remit. Is this definitely the best model of scrutiny? If it is, are we wanting to split it up or not? Outside of that broader conversation, I think that we've got in the unallocated items a bunch of things that we definitely should be slotting in as soon as practicable. I know that the learning disability provision, Glen and Lowfield stuff, there's stuff going through exec at the moment and upcoming on those. And I don't know when the best slot is based on the timetable of exec. Autism and neurodivergence strategy, I'm deeply uncomfortable with it being spring 2025. Another update came out this week from YDRF with a number of major concerns about the last few months and where we're at right now. The autism strategy for North Yorkshire has been published, and that went through full consultation, and this is being drafted. We need to be feeding into this process currently as scrutiny and not just leaving it until after mistakes have been made, particularly when there is current discomfort in the community. So I just want to flag that as a particular one. I've been talking about that for a long time, but other than that, I've not got
Work a task and finish group then.
I wouldn't be opposed to a task and finish group. I don't think it would be bad to bring it to full scrutiny either, even though it won't be a completed strategy, which we have discussed in the past as a potential to have the sort of outline of it.
I don't know how people feel at this. I wonder if we're best to discuss this via email, or would you like to discuss it all now? Councillor Runciman.
I'm very wary of rejigging the work plan off the cuff.
Yeah.
I would prefer it that you and the vice chair get together and circulate it to us.
Yes.
Because it depends on whether officers have the capacity to have reports ready, and whether the place that West officers has actually got a place where we can meet.
Yeah.
So I'd like it delegated straight back to you two and ask you to circulate the results of your discussion.
Absolutely fine. I was just trying to be very democratic. Perhaps overly democratic. Yes, you are right now. I wasn't questioning your commitment to democracy. So, is that okay with everyone? I think we'll do that because I've got a long list of reasons why things have been shifted around already. Okay. Right. Well, in that case, is there, sorry, any urgent business?
Yeah, just going to say the issue on unallocated items has been falling down the list now for about 2 years on reablement technology.
Ah, well, that's the task and finish group that you're part of. And I wasn't going to bring that up because Councillor Myers has already gone. But I do have a question about that, which is because Councillor Baxter was also a member of the group. And Councillor Myers and yourself, is that right?
Yeah.
And I was going to ask for an update on that, what's been happening and how it's progressing.
Yes,
because
so
we need to do that because that's why it's
progressed.
Yeah.
And what's been discussed was the idea of having a meeting that was different in style to other meetings to enable councillors to have a practical insight into the kind of technologies.
Yes.
And I was just going to suggest that since the 15th of January is listed as to be confirmed and deals with adult social care, that we might look to slot something into that
okay.
meeting.
And-
We've still got 3 months to plan for
Yes,
it.
and do you still see the task and finish group as viable? Because you've lost
My
one
personal
member.
feeling is that it would be better if all of us had a chance to see. I mean, our role is
Mhm.
is plural in all of this, isn't it? As councillors, simply by seeing this technology and learning about it, we're able to disseminate that to residents in our ward. So it has multiple benefits if we all have a practical understanding. So
Yes.
task and finish group, okay, but actually I think it'd be better if we
yes,
all.
and bring, we were hoping that you'd bring the results and we could explore what there is there with
Yeah.
practical examples at that time. So I think that's something again that we need to confer about.
We'll need to try again to find out who among the council officers is going to be able to help make that happen now.
Okay.
One of our challenges is continuous corporate memory loss. So we had a couple of people with expertise 15 months ago to help us do this, and I think both of them have left. So maybe that's our first task, is
Right.
to identify.
I can only
an
speak
officer.
from experience when
Yeah.
Councillor Fenton, myself and Councillor Stewart, we just got on with it ourselves, to be
Yeah.
honest, and we were quite, it was quite intensive for many weeks, but we really got the number of things and had meetings virtually and in person with people, and we didn't really have any help or support from officers at that point. But we did, it was really good. Councillor Fenton was phenomenal, I have to say. Maybe we should go up to him. Anyway, I think really though, I think now, apart from, is there any urgent business?
No.
No, I think I'm going to call this meeting to a close and those discussions will be held offline. So thank you all very much for your tonight, for coming tonight. Thank you.